Hi all, I'm Bincy here. Today I'm back with medical surgical nursing. So in this video we'll be discussing about benign prostate hyperplasia, which is abbreviated as BPH. It is simple. Benign means which is non-metastatic. Yeah. Then prostate hyperplasia. Prostate gland is getting enlarged. Okay. From the word itself we can frame a definition. It's enlargement of the prostate gland. So moving on to the definition, prostate gland enlarges extending up to the bladder and obstructing the urine flow, and which is causing or which is called as BPH. Simple, prostate gland is getting enlarged because of that urine flow or bladder. All the urinary organs, I hope you all remember: kidney, ureter, bladder, and urethra. So if the prostate gland is getting enlarged, bladder and the urine flow is getting obstructed, and which is ending up in BPH. Okay, moving on to the etiological factors which can cause BPH are age factor. Okay, age as an incidence, we can say around 50% of men are getting or are being diagnosed as BPH on the age of 50, and around 90% of men are being diagnosed in the age of 80. Okay, then any inflammation, okay, as we have discussed, like any pyelonephritis, cystitis and all can cause, or hydronephrosis. Then maybe it can be a hereditary cause, okay, or dietary, because dietary we can say increase in cholesterol. Then apoptosis is a new word, I think so, for you people. It is nothing that the cell has completely got damaged, and through any treatment we are not able to regain it. Okay, we can simply say that damaged beyond repair. Okay, then socioeconomic factors, then excessive production and accumulation of testosterone, estrogen and growth hormone. So these are the risk factors and etiology that can cause BPH. Okay, moving on to the pathophysiology. See, pathophysiology is very big, so I'm just making into a concise form so that you people can understand very easy. Okay, so due to etiological factor, hyperplasia, hypertrophy of the prostate gland. Because of the etiological factor, the prostate gland is getting enlarged or inflamed or swollen. Fine. So because of that, urine flow is getting impaired urine flow. When the urine flow is getting impaired, it is causing UTI, urinary tract infection. This condition we had discussed long back. I hope you all remember it. Because of UTI, what happens is like the urinary retention can occur, thickening of the urethral layer, dilation of the renal pelvis, which is ending up in hydronephrosis and other clinical manifestations. Okay, I hope you understood the pathophysiology. I would like to repeat it once again. Due to etiological factor, hypertrophy or hyperplasia of the enlarged prostate, which is ending up in the obstruction of the urine flow. When the urine flow is getting obstructed, it is ending up in UTI. When UTI is there, resistance of the muscle can end up in urinary retention. The urinary retention is causing thickening of the urethra, okay, layer of the urethra and ureter, and dilation or dilated of the renal pelvis, which is ending up in hydronephrosis and other clinical manifestations. Okay, so we can see what are the clinical manifestations. Through naked eyes, we can see it is a prostate gland, means enlarged prostate. Then dysuria, urgency and frequency. Okay, then urinary retention, azotemia, decreased urine stream. That means the urine flow is very much decreased. Irritation will be there, dyspnea will be there, nocturia will be there, and dribbling of urine. Dribbling of urine means once, so for example, when you have not tightly closed the tap, okay, water will be dribbling from the tap, right? The same condition is here. Okay, so moving on to the diagnostic evaluation of BPH, history collection, physical examination, digital rectal examination will be done, cystoscopy, prostate biopsy, okay, then ultrasound, urine analysis will be done, and in BPH there will be done a special test, that is IVP, that is intravenous pyelogram. This test is done only in the case of any complication. Okay, it's nothing, it's a procedure. The injection will be given through the help of a dye. Okay, a dye will be injected and we will be taking an x-ray of the urinary tract. Okay, that means from kidney, ureter, bladder and urethra. Right, it's a procedure. Name once again, I'll tell intravenous pyelogram. Moving on to the management. First is medical management. Medical management depends upon the cause. Okay, if there is no treatment, no symptoms, no cause. So what usually men do is, like, if there is no symptoms, they don't bother to have a treatment, right? They'll be waiting and watching. Okay, waiting, watching peacefully to see whether there is any symptoms occurring. But regular follow up checkups will help them to know whether the condition is getting worsened or not. Okay, then the next one is alpha adrenergic blocker receptors. Okay, I repeat, alpha adrenergic receptor blockers. This is a drug which is used to help the contraction of the smooth muscle contraction of the prostate gland as well as the bladder. Actually, in the neck of the bladder. Okay, why do we give this drug? Is like it to help the contraction of the prostate as well as bladder neck to increase the urine flow. See, our problem is urine is getting stagnated or urine flow is decreased. So this drug will help the urine to flow. For example, I can say we can give alfurazin and silodosin. These are the drugs which are coming under alpha adrenergic receptors. Then moving on to alpha reductase inhibitor. Okay, alpha reductase inhibitor. This is given to block the testosterone. See, in the etiology we said that it's an excessive accumulation and production of this testosterone. So this alpha reductase blocker is to give or is to block the testosterone, and it is said the results or the report says that up to or approximately 25% of the prostate size is getting reduced if this drug is given continuously for 6 to 12 months. Okay, for example, I can say avodat. Okay, so that was all about medical management. Moving on to the surgical management. See, for BPH, mainly surgical management is being asked for 5 marks. Okay, and it's very important. Okay, so surgical management, first one is suprapubic prostatectomy. Ectomy. Okay, it's nothing, removal of the gland through an abdominal insertion made into the bladder, and prostate gland is removed above the pubic bone. Okay, it's a small procedure. Suprapubic prostatectomy means it's just removal of the gland, okay, through the abdominal insertion. The gland is removed above the pubic bone. Fine. The next one is retropubic prostatectomy. Retropubic prostatectomy. Nothing, lower abdominal insertion will be done to remove the gland. Okay. And this procedure is done only for large prostate glands, which has been hips and all getting involved. Okay. Usually retropubic prostatectomy is not performed. Okay. For small prostatitis and all. Fine. Next one is balloon urethroplasty. It's nothing. A tube with a balloon will be inserted in the tip, okay, and it will not be inflamed. So once it is inserted, okay, where the block or where the stent and all is there, it will go there, okay, and the balloon will get inflamed where the urine flow and all is there, the urinary retention, the bladder neck is contracted and all, no, so there the balloon, it will go and it will get inflamed. That is known as balloon urethroplasty. Then TURP is very much important. TURP is the most common procedure done for BPH under endoscopy. Okay, TURP is done for the treatment and to prevent the complications of BPH. So till now we discussed all the management which can treat or which can reduce the signs and symptoms. But TURP is done to prevent the complications of BPH. Then, during TURP, a tube is inserted into the tip of the penis to urethra. TURP is done to relieve the moderate to severe symptoms which is caused by enlarged prostate hyperplasia. Okay, so I hope you all understood about BPH. Okay, it's very important. Please watch this video, and if you have any doubts, please get back to me. I hope you understood. Thank you. Have a nice day.